Final presentation before the panel is from Dr. Natasha Roberts and Dr. Midori Nakagaki, and they're talking about the really exciting PRAGMATIC trial, which is one of our flagship trials at the moment.
So I was very pleased to see Midori. So I'm Natasha Roberts. I'm the implementation science lead, and I'm a nurse, and Midori is a pharmacist, and she has all the expertise with the PK modelling side of things. So the PRAGMATIC trial is an MRFF-funded study that we have through CRE Respond. The methodology that we've built into it took a lot of work, a lot of partnership, with lots of different people. This is an international trial, and so it's a hybrid effectiveness trial. The intervention is looking at using TDM and genomics in voriconazole, and embedded within it we have implementation science sub-studies and cost-effectiveness sub-studies. Jacinta, who presented earlier today, is leading a big consumer, a proportion of it from the co-design perspective, working with consumers across all of the different sites. But I will hand over to Midori because this is really her area of expertise.
Thank you, Natasha. And there are so many team members in the room, and it makes me nervous, but I'll try anyway. So invasive fungal infection, this is a significant complication during treatment of hematological malignancies. I work in hematology and BMT unit, and it's not super common, but it happens from time to time, and it can be very serious. Many of our patients are already on the prophylactic antifungal, mostly fluconazole. So when the invasive fungal infection is suspected, it's likely to be mold infection, and voriconazole is the first line treatment. So we do monitor trough levels and adjust the dose, but there are high in the patient's variability, and we know this is due to CYP2C19 enzyme polymorphisms. And there are definitely hyper and poor metabolizers, and we struggle dosing voriconazole for these patients. Some of our team members did preliminary work. I've just got the result here. According to that, so voriconazole level is everywhere. That's okay. This is the first TDM, and only half of the patients are within the range. The important thing is the second TDM, which is more than 2 weeks after the treatment started. Nothing's changed. It's still everywhere, and only half of the patients achieved target exposure of voriconazole. So definitely we need something better. So in this PRAGMATIC study, we propose precision care and comparing the outcomes with the current standard care. So precision care uses genotyping, CYP2C19 genotyping, as well as PK software in early stage, and inform the early dose adjustment. And the standard care is, of course, that weekly trough levels only. Our primary objective is to compare the proportion of patients achieving therapeutic voriconazole exposure at day 8, which is quite early. Secondary objectives include clinical success, which is absence of the clinical deterioration or needs to change the therapy. Antifungal exposure, voriconazole exposure over the first 28 days of the therapy, and so comparing the dose recommendation between genotyping only, TDM only, or combination of both. And the feasibility of precision care using these interventions in timely manners, and comparing clinical success between different genotypes. And as Natasha mentions, we also have a sub-study looking at the implement, if this precision care is implementable by looking at fidelity, feasibility, acceptability, and cost effectiveness. This is the actual procedure. We will randomize patients we will randomize 104 patients in either standard of care or precision care. Standard of care up here, this is just standard TDM, which is trough level. That white arrow is a blood sampling, but this is for the post-study analysis. Precision care here, we will do genotyping on day 1 and blood sampling for PK software, day 1, 2, and 4. And the rest is the same as standard care, but the first dose adjustment happens on day 5. And we will see the trough levels on day 8 and see if it's therapeutic range. So Natasha mentioned that, but it's a MRFF-funded, national multi-center trial. The Fred Hutchinson Center, Cancer Center, which is very famous in cancer care in Seattle, is participating, and as well as multiple Australian sites, both adult and children's hospital. Okay, I didn't make the thank you slide, but thank you very much for listening.
Thanks, Midori and Natasha. We look forward to the outcomes of that study as they come through. So that brings us to the end of the presentations. We now are going to ask you to move into the atrium where we're going to have the panel discussion, which is going to be led by Hafiz Abdulaziz, and I'll let him introduce the expert panel who's going to be talking about the use of continuous infusions, what the outcomes from the BLING study were, and what the implications are for clinical practice, as well as future research directions. Thanks, everyone. I look forward to joining you out in the atrium. To those of you that are online, thank you very much for your participation today. It was wonderful to have you join us, and we look forward to sharing more exciting news and outcomes from our studies with you in due course. Please don't be shy in reaching out to us to discuss anything that's related to these talks, and we'd be very happy to communicate with you. Thanks very much, everyone, and bye from UQCCR.